sick-day holidays from their treatment, and indeed the interactions of their prescribed medicines with over-the-counter medicines, especially in the elderly. You illustrated very nicely the NSAID plus the ACE inhibitor. We don't do it very well.
In my clinic yesterday, I had a pre-registration pharmacist, and almost every patient, it was about drugs. It's a sugar form. So I try and educate them, and I tell them they must not take non-steroidals, and they should stop their medication. And they all get a copy letter, and it's in bold at the top. And I reiterate that, but I think it needs to be widespread in primary care and secondary care. It needs to be widespread.
There's a question online from Dr. Ahmed Mohammed, who's from the Kasralani School of Medicine in Egypt, and he asks, is there any way to differentiate NSAID-induced simple acute kidney injury and acute interstitial nephritis?
So if you have a drug-related interstitial nephritis, you look for eosinophilia, you look for other evidence of allergy. The time frame and the context can be useful. Often this happens in the community, and meprazole is a common cause of that in our practice. Whereas AKI typically would be in the context of an NSAID with other factors like dehydration, ACE inhibitor, etc. So often clinically they're relatively different. But I think the point is made that you have to think about it, because it may be. And the first patient I showed you who had the brufen overdose, I biopsied him because I was concerned that he may have a grumbling interstitial nephritis in his kidney. And actually it was a bland kidney.
Right.
So you need to think about it. It's a good question.
Yeah. So thinking about it is the key.
Yeah. It's about clinical context, and often AKI is different to a drug-related allergy.
Okay. Yeah.
Brindley Intensive Care, Canada. It's a whole gigantic topic. It's back here to speak, but initiation, frequency, and type of dialysis seems to be driven as much by culture and availability of resources. I wonder if you could just comment on, based on your AKI, when you should start.
Yeah. I think that's one of the issues to be addressed is would early initiation of therapy be advantageous, and we just don't know. So you're right, really it tends to be based on clinical context, which is to do with volume, potassium, acidosis. My view is that at the moment I regard that as key, because we certainly see patients who are commenced on dialysis, they have anticoagulation, there are issues with bleeding or post-operative patients, so I go very much on clinical context. And also trying to stop dialysis. We had a patient on the ward over the weekend who had uremia, but he was getting better and he was polyuric, and there was no real indication to dialyse him again because he had lots of other things going on. So there's no answer on that. These areas I think we need to have more trials, actually good RCTs to address those questions.
Good. Okay, I'm going to draw that bit to a halt. Thank you very much, Jeremy. That was most instructive. So our next speaker is John Morris. I'm delighted, John, that you could come and address us. John works in Glasgow as a GI consultant. Quite a number of roles and titles, really. You're Director of West Scotland Endoscopy Training, and John had an interest in training and the cutting edge of endoscopy, novel techniques, imaging of small bowel for quite a while. He runs a complex inflammatory bowel disease clinic. Research areas include advanced endoscopic imaging, or mucosal disease treatment, novel endoscopic therapies. Also, John's taken on the role of Treasurer of the Scottish Society of GI, committee member of the British Society, member of JAG, very active member of JAG, works in QA groups. So John, you've got a lot of hats, and it's your choice as to which ones you're going to wear today in telling us about GI. Thank you.
Well, thank you, John. And in preparing for this symposium, when I spoke to John about how we should move forward, we decided that actually there's so many acute GI presentations that come through the front door that we should try and focus. So I'm going to limit my discussions today to two subject areas. The first is upper GI bleeding, the second is alcoholic hepatitis. Now, as someone from Edinburgh working in Glasgow and coming back to Edinburgh, the subtext here is not a tale of two cities, but a tale of two scoring systems. So I want you to watch out for those, please. Now, GI bleeding is a very common emergency. You are all dealing with that probably on a daily basis on the post-take ward round. The issue really for us as gastroenterologists is that, as this UK audit shows, the mortality over several decades has really been unaffected by our interventions. And what's more, if you have a GI bleed as an inpatient, as this slide shows, the mortality is still really very significant. Now, there are several issues to this, and we're going to address these in part with a series of 5 questions. The first issue, of course, is whether we can actually improve the front door care, and by that I include medication access surgery. So the first question, how do we risk stratify patients? I guess that many of you are doing that anyway as patients present to the front door. Essentially, there are two commonly used clinical scoring systems in UK practice. The established scoring system is the Rockwell score, and more recently, of course, not to be outdone, we in Glasgow invented the Glasgow Blatchford Score. Both of these are recommended in terms of assessing patients. The Rockwell score is essentially quite a complex score, but you can see comprises 5 different components: the age of the patient, whether the patient was shocked, whether there's comorbidity, the diagnosis, and whether there's stigmata or recent hemorrhage. The problem with this score is that you're required to have an endoscopy for complete risk assessment, and therefore the need for another score exists. I'm sure many of you will have seen the publications in the Lancet regarding the Glasgow Blatchford Score. Now, in Glasgow, we like things pretty simple. So we like to have things that are readily available and that you don't need a math degree to calculate. So if you look at the factors that are associated with the Glasgow Blatchford Score, these are parameters that should be available to every one of us with a patient on EMU. The FR1 should know the answer to these questions. So blood urea, the hemoglobin, the systolic blood pressure, and whether there are any other markers of disease, and essentially a numeric score. This has two potential roles. Firstly, identifying those patients at high risk, but more importantly, also allows us to stratify those patients who probably don't need to come in at all, and therefore reducing the demand on our services. And this gives you an example of the two scoring systems in action. You can see here the green bars are the patients not requiring intervention, and the blue are those patients requiring intervention. That is people who require endoscopy as part of their ongoing management. And you can see from the top graph here that the Blatchford score clearly identifies a cohort of patients. So if you score 0, your requirement for intervention, chance of you dying is 0. So there's really a very good scoring system, as opposed to the Rockwell score, where you can see even with a Rockwell of 0, there are some patients who actually died with a Rockwell of 0, which is kind of puzzling. And when we look at that using ROC curves, you can see here the blue curve is the Glasgow Blatchford score, the green is the full Rockwell, which of course I'll remind you requires an endoscopy, and the red is the admission Rockwell, and the Glasgow Blatchford is performing on that occasion in a far more superior way. In terms of applying admissions to AAU or in managing the ever-increasing number of medical admissions, I'm sure some of you will already have this in clinical practice. We have been doing this for quite some time. The patients who score Glasgow Blatchford of 0, the front door team do not admit these patients. So they go home, they don't require admission, and you can see here in terms of the potential benefit of, potentially 22% reduction in admissions. Now we're extending this to a Glasgow Blatchford score of 1, and in fact some hospitals in England are now extending this to a Glasgow Blatchford score of 2. So you should see less of the people who have vomited a pint of Guinness and more of the patients who actually require the acute physician or your intervention on take. So moving on to the question of upper GI bleeding and blood transfusion, some interesting data on this recently. Some sort of retrospective data here from 2010, the UK analysis or audit of GI bleeding, showing that blood transfusion, as we see in ITU settings and settings of sepsis, is not always beneficial. I want to draw your attention to this upper graph, and you can see here using the Rockwell score that for every division of the Rockwell up to 8, a significant increase in rebleeding in patients who were transfused. Now that's an interesting observation, but this has been brought into sharper focus recently with data from New England Journal of Medicine, which identified 2 different strategies for blood transfusion in patients presenting with acute GI bleed. The first was a restrictive strategy aiming to transfuse patients whose hemoglobin had fallen below 7, with a target range of 7 to 9, and the second was a liberal strategy, patients whose hemoglobin had fallen below 9, as a transfusion threshold or output of 9 to 11. Can I just say at this point, very importantly, if the patient is exsanguinating, do not wait for the hemoglobin to come back. Give these patients blood. I know that sounds silly, but the number of times I've been woken in the middle of the night by an FY1 telling me that the Glasgow Blatchford score is 11, and actually they should have been dealt with by the renal physicians because actually they've got septic shock and they're in renal failure. So a common sense approach here, but nevertheless, quite an important message beginning to come through. A very different outcome in terms of survival in patients patients who receive rural blood transfusion. That's probably all I want to say about that at the present time, but in our hospital, especially for patients with liver disease, we're aiming for hemoglobin 7, and we're now beginning to move towards that for patients who we think we have peptic ulcer bleeding. So I'd encourage you on the posters in ward round to just consider how much blood you're going to be given. What's the current optimum therapy for patients with bleeding peptic ulcer, and how effectively can you access it, and how effectively can I deliver it? Well, here's a graph, if you like, that it gives you an idea of the relative risk of rebleeding. So we've got to focus on stopping these patients from rebleeding. The relative risk of rebleeding is shown here as percentage terms associated with endoscopic stigmata that I might see or John might see on an endoscope. I think this is quite important because when you're receiving endoscopy reports back saying that there was a visible vessel or a spurting visible vessel, you need to have some idea in your mind as to how much risk there is that that patient will rebleed. And we really need to focus all of our resources on the three categories here: the spurting vessel, the non-bleeding visible vessel, and those with adherent clot. Now, there's nothing more likely to engender a tachycardia than the current recommendations, which are that we should remove that clot at the time of endoscopy and then treat the patient. And that's a tachycardia for the endoscopist as opposed to the patient, and therefore we need to be skilled. And the current recommendations suggest that the first three categories are those who are treated, and the other patients, so if you get a report back from an emergency endoscopy saying the patient has got a flat-based ulcer, they've got a clean ulcer base, send those patients home the same day. Don't wait for 2 days, don't think that something might happen, send them home the same day. You're perfectly safe. The optimum therapy for a bleeding peptic ulcer is so-called combination therapy. So again, understanding the report you get back from endoscopy, if you have a patient that comes back who's not had dual therapy or combination therapy, they've had suboptimal therapy. We combine two modalities. The first is injection of fluid, usually 1 in 10,000 adrenaline. There's a vasoconstrictive effect of that, but actually it's probably a volume effect on blood vessels. And the second thing is tissue damage. So we actually try and coagulate the vessel. And you can see here, this is the so-called heater probe, which allows us to access the bleeding blood vessel, and with sequential pressure, we cauterize the blood vessel. That's been slightly superseded by the use of clips. Again, surgeons have laughed at us in endoscopy when we've tried to explain to them that anything over a 2 millimeter blood vessel could be cauterized through an endoscope. And now we're seeing an ever-increasing number of endoscopic accessories where clips and other devices are used. The problem is that there's a considerable skill set required for this, and in addition, you have to have a skilled endoscopist available who's on call, who's not otherwise dealing with the COPD or the elderly patient with falls. Now, what about effective endotherapy? So how good are we in the UK actually providing that service to you? Well, I think you probably know the answer. So this is a UK audit data, and only 38% of patients who should have been treated in 2007 were actually being treated appropriately, with a stunningly high mortality in those people who did not receive the therapy. So the next time your gastroenterologist say to you, look, we really need to provide a GI bleeding service, you may want to think again. Is there a difference? Many hospitals are now providing Monday to Friday care with emergency endoscopy, and this is real Scottish data showing the difference in 30-day mortality from GI bleeding at weekends. We may hear more about this. Like other medical conditions, you can see quite clearly that the blue graph is the weekend mortality. Significant difference in mortality if you get admitted with a peptic ulcer disease on Friday to 11 as opposed to Tuesday at 11. And length of stay, again in terms of planning hospital admissions, very clearly the longer time it takes for your patient to get an emergency endoscopy, the longer they're going to stay in hospital. There's also a problem with endoscopic therapy, and that is it can be complex to deliver, and just when you think you've got it right, it all goes completely wrong. So I'm going to tell you about a new device that's made by Cook Medical. It's really sort of beginning to set the heather on fire. This is essentially a gun with a powder reservoir and an application catheter. It's called hemospray. And here, very simply, a catheter is passed through the working channel of an endoscope. You can see that the powder then coats the bleeding site. There's rapid absorption of water, forming a barrier, and that this way successfully achieves hemostasis. And we've got a paper currently in EPUB ahead of print, just with the earliest world experience on this, and it's beginning to allow us to target lesions that were otherwise well beyond our capabilities. Now this, even for Glasgow, is a significant lead. see here with catheters being advanced and by spraying. And this is technology that's evolved out of the battlefield and following all the wars that we've been in. So you can see within seconds, hemostasis, that patient stabilised, they don't have the hypertensive kidney injury that we've been hearing about, so really quite an exciting prospect for the future. And you can see here the results of our own study showing that just with one modality and very short action, 85% primary hemostasis rate. So with the most challenging patients, then we're seeing a benefit. So how can we improve matters post-endoscopy? Well, I think many of you will already be familiar and probably refer to the Hong Kong protocol. It's really, I think, quite important to realise that that is designed to be delivered post-endoscopic therapy, and yet virtually every talk I ever give and every hospital I ever visit, people give this ahead of the endoscopy. I think this is just a UK phenomenon because of the absence of access to emergency endoscopy in a timely fashion. Clearly showing that IV PPI, so a simple intervention in the AAU, reduces 72 and 7-day recurrent bleeding. So a very exciting outcome. Just one final word. This is where we think we're catching up with our physician colleagues, the cardiologists or the respiratory physicians come up with a new anticoagulant that they want to use, and that seems to engender problems for us. I just want to highlight very clearly, because I think this is an area that acute physicians will focus on much more. Be sure, we've heard about checking the drug cards, be sure these patients haven't had a coronary intervention, they're not on clopidogrel. You will do more harm to that patient by stopping their clopidogrel, potentially putting patients at risk of thrombosis, than if we actually have an absence of GI bleeding service. Very impressive data here showing that by the time you get to day 5, if your patient comes in on Thursday or Friday, if you stop the clopidogrel, that's then into critical risk. So the recommendation, critical recommendation is make sure the cardiologists know that the patient's in hospital and discuss with them and hopefully local gastroenterologist an early endoscopy. Excuse me. Right, now, post-take wardrobe. The second patient, you may be told by the ST2, you've got an alcoholic here, Dr. Morris. Some of you probably have already thought, well, this would be the usual, the binge drinker. So a 56-year-old male, jaundice, recent alcohol binge. These are the blood results, you can see for yourself. Here's a question. This patient has no stigmata of chronic liver disease. The only thing you can find is their jaundice. I have a show of hands for how many people think this chance of survival is 90%. There's a few. Okay, how many people think it's 50%? Quite a lot. Well, let's see if we can explore this a bit more. Again, there's a political issue to this, which is that as we make alcohol more affordable, then all of our hospital data suggests that we're going to see more and more people with acute alcoholic hepatitis. This is a killer of a disease. Bear in mind that this is not the patient who's got all the stigmata of chronic liver disease, although there can be an overlap. This is the patient who otherwise looked well, is just gone a bit crazy on an alcohol binge. They've come in bright yellow. And so how do we identify the patient with alcoholic hepatitis clinically? Well, the first thing is we need to have clearly in history a story of recent alcohol excess. Unfortunately, for some people, that doesn't have to be that they're drinking heavily all the time. They just have made a mistake. They've gone off the rails. We're definitely looking for the patient to be jaundiced. The bilirubin greater than 80 is regarded by most authorities as being in the right range for this. We want to exclude other liver diseases, and we're looking for actually rather low level of transaminases, particularly with an AST ratio which is higher than ALT. The patient may have a big liver, but they may have nothing. And if we were to turn to the literature to see how we would manage these patients in a UK hospital or other hospital at the moment, then we could turn to the established literature. And what that clearly shows is that before we can make a diagnosis of alcoholic hepatitis, we should be thinking about getting a biopsy to prove it. Let me tell you, if we wait that long, this patient will suffer significantly. So at the moment, we regard biopsy to prove alcoholic hepatitis as obsolete and certainly not part of clinical practice. Again, we're coming now back to our second scoring system. And when I started having an interest in this as an acute young consultant, I was frustrated because I was asked by clinicians in my PU, well, what's the chance of this patient surviving? I was asked by renal physicians, should we dialyze this patient? Are they going to live? They're really looking bad. And I was frustrated because I don't have a degree in mathematics, and the established scoring systems that has told us how severe someone's alcoholic hepatitis was were really extraordinarily difficult to calculate, and as I said, other than a pure maths brain, it'd be difficult to calculate these. So we said about Colleague Forrest, who really has done a lot of extra work on this. easily that leads to a numeric score rather than a logarithmic scale, rather than a ratio. There will be a score, and we put a number of variables that we thought were reasonable into univariate analysis, followed this up with multivariate analysis, and these were the issues that came out: the age of the patient, the white cell count, the urea, the prothrombin time, and the bilirubin. Actually, the urea didn't quite come out, but as I would certainly echo the views of our last speaker, probably the best thing you could do to any alcoholic patient coming through the door is to give them some IV fluids. Whether they've got ascites, whatever, give them some IV fluids, because when these people start to get renal impairment, they die. They're virtually unsavable. So we actually falsely forced back in an arbitrary urea score into this because we felt that was really critically important. So you get a numeric score, very easy to calculate, and the data that we gathered both retrospectively and prospectively showed that the gas score of greater than 9 was very good at predicting outcomes, much better than established scores such as the discriminant function, BF. That was true whether you calculated at day 1 or day 9. So all of our admissions in Glasgow, and I'm sure in many of your hospitals, have these scores almost off road now. It's so much part of our practice. So what about our patient outcome? We had a 9%, we had a 50%. Is this a thumbs up or a thumbs down? Well, if we look at the scoring systems, the discriminant factor would be 39, poor prognosis. The MELD, which is an international scoring system, and AB1C, would also give us a questionable survival, and the gas would be equal to 9, indicating in our view a poor prognosis. The question is, well, what difference does it make? There's been ongoing discussion about steroids for some time in terms of patients with acute alcoholic hepatitis. Now, sometimes it's now become ridiculous, so that this was first mooted in 1978. But I'm glad to say that there's now an ongoing UK prospective study looking at this. There are some meta-analysis that would suggest that steroids are beneficial, but this has never been tried in a sequential prospective manner. Pentoxifylline is the other agent that's tried. From our own data, and I just want to share this with you, you can see here that the patients receiving steroids on pentoxifylline with a gas score of greater than 9, there was a significant difference in survival. So we were able to increase the survival from 54% to 76%. So there's a 50% benefit in terms of treatment. And certainly from our perspective, this is an ongoing part of our algorithm. So alcoholic hepatitis are receiving steroids in the clinical trials. So we can come back to our algorithm. We treat the sepsis at admission. We don't hold off steroids while we're treating sepsis. If your gas score is greater than 9, you're regarded as high risk, and we put you straight on to steroids, 40 milligrams for once a day for a week. Low risk patients, gas less than 9, not a proper nutrition assessment, adequate hydration, treat any complications of cirrhosis. These patients will get better. Again, coming to the algorithms, you can see here that the suggestion is that you should calculate again a logarithmic scale. Well, we've tried to make that a bit more simple as well. So a real sort of practical guide for you on this one is observability at admission and the bilirubin at 1 week. If they had a week of steroids and 25% falling bilirubin, continue steroids at 40 milligrams for a further 3 weeks, and then taper over 2 weeks. And then you can ask yourself, well, did it work? So from our own data, you can see here we had a cohort of 182 patients that we studied. We DF greater than 3,270, ongoing number with a gas score of greater than 9, so we think that's the one to aim for. So 100 patients treated out of 182, and here's the outcomes. So we've got 64 patients who were treated and survived, 20 who did not, and then equal numbers who were untreated and then survived or died. And what you can see from that quite clearly is this summary, which is that if your discriminant factor is greater than 32, but your gas is less than 9, you're going to survive anyway. If your gas is greater than 9 and you're treated, your survival will be 76%. But coming back to my initial question in this talk, if you have a gas of greater than 9 and you're not treated, then you've got a 50% chance of dying. So that's, I hope, a practical view on 2 scoring systems and 2 common problems in gastroenterology. Thank you.
So this presentation is now up for discussion. We have nothing from here. John, I'd like to kick off with a question. You alluded earlier on in your talk to the importance of liver biopsy but the fact that you couldn't actually get that within the time that was thought to be helpful, and therefore you've ruled that out in your algorithm. Why is it that we can't get biopsies when we need to get them? What gets in the road, and what can we do to improve that?
Well, I think there's a lot of misconceptions about liver biopsy and just how much diagnostic help that you get from them anyway, John. We see a lot of liver biopsies where there's no real benefit, and the differential in terms of diagnosis is low. I hope the point that I was trying to make is that there are probably, from international studies, the patients that are regarded as being inverted commas alcoholic hepatitis are probably not buckfast drinking patients that we see on a regular basis. So the access, well, interventional radiology isn't there, transcervical biopsies, patients with coagulopathies. The take-home message is it doesn't make a difference. You can use clinical scoring systems.
So you wouldn't be pushing to change the status quo, but we can get by without histology. That's what we're like.
I don't think that liver biopsy has got any place in the management of these patients.
Okay. And what about out-of-hours access for interventional endoscopists? Are we anywhere near where we need to be? And if the answer is no, how do we get there?
Well, I think we're moving in the right direction, Tom. I think there are the simple things that we can do right. So having a protocol in your AAU, having a scoring system, having simple things, policy for transfusion, having policy for IV BPI, that has actually made a difference. So the mortality in general is falling for GI bleeding in the UK. Over a decade has gone down probably about 1 percentage point. How do you do that? I think it's about organisation. The NICE guidelines would suggest that unless you're admitting about 300 patients with GI bleeding per annum, you shouldn't probably admit any, and you should work towards network. So the possibility of triaging someone according to a scoring system, people at high risk. We've had a lot of discussions about this, and as you know, there's been quite a lot of spoken from the Scottish Executive. But the reality is, unless there are, I think, 9 or more gastroenterologists or doctors who are able to deliver endoscopic therapy in your hospital, you're probably doing a disservice admitting these patients.
Good. Thank you. There's a question here. Yes, sir.
Mark Andrews in Norwich. Not a gastroenterologist, which will become obvious. How can endoscopists help us in those early couple of days with a complex patient? We're talking about an elderly person with renal failure. They are anemic, they are a bit hypotensive, but they're also on antihypertensives. The history is not clear from the residential home. Very typical scenario, I'm sure lots of people will recognise. It's often seems to be quite keen to know whether there is a potential time bomb in this elderly person's GI system.
Well, I think obviously the critical point is doing the simple things right, so stopping the antihypertensives and all the rest of it. I think we're seeing a process of evolution as healthcare is changing, and the number of receiving units is going down to bigger units. I think you will have much more ready access to emergency on-call 24/7 GI bleeding rotas. We're half of the way there. So if I was making a case, what I would be asking for is a 7-day-a-week morning bleeding service, which we run. So that doesn't require anyone to be on call out of hours. In our hospital, what we have is that all the gastroenterologists do contribute to acute general medicine, but they do a slightly lesser amount of that, which allows a 1-hour endoscopy service every morning. So there are different hybrid models. I mean, we have to be realistic that not all gastroenterologists are going to be able to be on call all the time. I think we do have to move away from the idea that the friendly gastroenterologist in the DGH is called in on Saturday night, assuming
medical students, which includes IUI, and the roles have now reversed from doyen of clinical pharmacology to mere humble disciples. And I'm really pleased to see you today. Tom is a professor of clinical pharmacology in Dundee. Research interests are hypertension, cardiovascular disease, pharmacoepidemiology, I can almost say that, and drug safety. He's current president of the British Hypertension Society, and you're going to talk to us today about what we need to know about drugs.
Thanks very much, John, and thanks for asking me to speak here today. I'm actually going to start with the quite mundane. I'll probably move on to the sublime and ridiculous, but I'll start with this mundane. Here's a 38-year-old man who's got an office blood pressure of 148/98 at screening, and he comes along for an insurance medical. So what should you do next then? Should you repeat his blood pressure measurement? Should you repeat it over a number of visits? Should you get the nurse to do it? The nurse is always put the readings. Do you do a home blood pressure? Or do you do ambulatory blood pressure? Now, I'm not going to torture you with clicking your things. I'll tell you what the answer is. The answer, look at this fella. The answer is that you now have to do an ABPM according to NICE, and that came out a couple of years ago. And that's changed the world of hypertension, because it's changed the definition of hypertension. It's now based on ABPM. It's actually quite hard to deliver this in the real world. We have an excellent service in Edinburgh, and I wish we could exhume Paul Hatfield from retirement and get him to roll it out throughout the rest of Scotland, because we struggle to deliver the service elsewhere. So NICE made that decision because it was cost effective to not treat hypertension if you had a normal home blood pressure, or quite cost effective if you didn't know it, and this is the data they used. So assuming that you didn't, and they've given a benchmark for how to do home blood pressure monitoring. Now, if you want to find out which home monitors to buy, which are validated, because many of them have not been, and you go to the British Hypertension Society website, we've got a comprehensive list of those that meet the current standards. But NICE also gives us a good definition of hypertension. So you've got a clinic pressure of 140/90, or an ambulatory monitor or home monitor during the day of 135/85. And those are different. And that's the message to get over there. Now, we can argue about how much difference there should be. Some people think there should be a bigger difference, but this is what NICE came out with. And then they define stage 2 and stage 3. They also defined a target, which was 140 systolic. And are there any DPs in the audience today? A few DPs, 1 or 2. Because the BMA have now released you from this NICE target. We're going to drop the QOF target from 150 down to 140, but this has now been retired. Isn't that a good name for it? I have a lot of things in QOF I've been retired because they were too hard to do. So I don't know whether that's good or bad, but GPs now still have a target of 150. So what would you do with this chap then whose blood pressure of ABPM is elevated, no LVH, normal investigations, normal kidney function? What would you do with him? Well, what NICE says is that if he needs stage 1 hypertension and he's no cardiovascular risk, which you wouldn't have at 38, then he should just have a lifestyle intervention. But the slightly confusing thing is, they said, if they're younger than 40, consider specialist referral. So I'm now seeing some patients in the clinic who I'm supposed to investigate, who wouldn't be treated with drug therapy. There's a little bit of, I think about 20 and they've got that level of blood pressure. You probably want to for secondary hypertension, but there's a grey area there. So the other thing that NICE did was they swapped thiazides for calcium as the first choice in the elderly. I don't think we should get too toxic about that. The important issue is lowering the blood pressure. So I'm going to move now away from the mundane to this chap. This is Murray Esler. Murray Esler worked at the Baker, which is a research organisation in Melbourne in Australia. And, oops, oh dear, I'm not done that, am I? Can I go back? I've gone to the website, haven't I? There you go. I'll use the button from now on. I should have taken the links out. Murray's been interested in renal nerves. Now, this is a renal artery, and along the appendice of the renal artery are these renal nerves. So why was he interested in those? Well, he thought that renal nerves fed information up to the brain about your blood pressure from the kidney, and he also thought that the brain fed information down to your kidneys about how to control blood pressure. And so he actually published this letter in 2009 New England Journal saying that if you ablated the renal nerves, you got good control of blood pressure, in this case uncontrolled hypertension. And this is the data he showed. This was the muscle sympathetic nerve activity in the patient with high blood pressure. And when you ablated the renal nerves, it got less and less, and the blood pressure went down remarkably. And this was followed up by another study, but how they did the renal denervation was this thing. This is the Simplicity renal denervation catheter system. And basically this works by you stick it down the renal artery and you stick it onto the endovascular side of the artery and you zap. It might be easier seeing here, you zap. And then you zap in a sort of circular spiral all around the renal artery and you zap all the renal nerves. And this was their proof of principle study in the Lancet, which showed really remarkable falls in blood pressure. But there's no control group here. This is just patients being treated. So that was followed up by the Simplicity 2 trial, which had a control group. And the control group was people medically treated. So we could argue about whether that's a good control group, but there was really remarkable falls in blood pressure. Just online now at the Lancet is a follow-up at 3 years from Simplicity 1, which suggests that the blood pressure reduction wasn't just acute, and the renal nerves clearly didn't grow back over a period of 3 years, and the blood pressure was still reduced. Now, there's lots of these little catheters now coming on the market and available. There's probably 20 or 30 of them now. And this is a big growth area, and lots of Harley Street cardiologists are now offering to cure your hypertension for £5,000 a pop on Saturday morning. So certainly that's created a lot of interest in this technology. But we're all await this Simplicity 3, and this is just the trial protocol, because the FDA required that they did a sham procedure controlled study, because there's a group of people who really think this could all be a placebo effect, because you don't take your tablets, you go in a hospital, you have renal denervation, and it's quite painful to have your renal nerve zapped. Don't want that again, I'm going to take my tablets. So we wait to see whether the sham procedure control trial will work. So I'm going to talk briefly about some other devices: bladder reflection, carotid body, deep brain stimulation, the AV fistulous anastomosis. And I'm not going to talk about CPAP or respirate. So I don't know if you've probably never heard of the Barostim system, but there's now a second generation one. And these things wrap around your carotid bodies surgically, and you switch the box on. There's now a second generation that just puts it next to one of the carotid bodies, which seems to work just as well. So this works on the idea that your carotid sinus tells the brain what the blood pressure is. So if you stimulate it, the brain gets filled in thinking, ooh, blood pressure is really high, we'll lower it. And does it work? Well, here's somebody who's had one of these devices, and you switch the box off and the blood pressure goes up, and you switch it on, it goes down, switch it off, switch it on. It does seem to work, doesn't it? That seems pretty convincing. And even over a period of about 3 years, it seems to continue to work. And this is despite people probably reducing their blood pressure therapy. So, would you have it done? That's the question. Would you have that done to you? Have some leads put on your carotids? I'm not totally sure, but following on from that, there's now a lot of investigation into whether we should ablate the carotid body in people with severe hypertension. Now, the trouble with this is it's irreversible once you ablate it, but it could be a prolonged cure. But would it cause postural hypertension, etc.? Well, we wait to see. Would you have this done to you if you have really severe hypertension? Would you have a catheter stuck in your brain to stimulate your periaqueductal gray? Would you have all that? Would you submit any patient to that? Well, it does seem to work, but I'm not convinced about this particular. I'm not convinced I would have given somebody with a blood pressure 140 over 70 deep brain stimulation, but perhaps we'll get better data in the future. So I would probably not give deep brain stimulation to my mother. I'd sort of keep it for my mother-in-law. It's really a mother-in-law intervention. Now this is another strange device, and it's rather bizarre that this should come along. This little differ here is put in percutaneous is that you actually create an AV fistula in your iliac artery. That sounds silly, but this little device is quite easy to put in. It takes about an hour, and you create the 4mm fistula in your iliac artery and your iliac vein. It's called the ROX procedure, and it's said to lower peripheral vascular resistance, restore compliance to the vascular system, and it's fully reversible. And of course, people think, well, that causes hypocardiac failure, etc. Well, it doesn't seem to. It was developed initially for COPD. It seems to improve symptoms in COPD patients. But when they did their COPD patients' blood pressures, they found that, wow, that's a big reduction in blood pressure. So this is now in a 200-patient trial to see if this is going to be a long-term viable treatment for resistant, start off with resistant hypertension, but possibly other forms in the future. So I thought we would go from the sublime to the ridiculous. I'm not quite sure how this system works. It's said to increase cardiac output and increase blood flow to the kidneys and reduce peripheral vascular resistance, but I'm still not totally convinced, but it does seem to lower blood pressure. Now, at the American Heart this year, anybody who's interested in renal artery stenosis and what we should do about it, the answer is we should treat it medically, I think, until we get any better data. This is the CORAL study, and it's different from other studies in that, firstly, the patients who went into it definitely had hemodynamically significant renal artery stenosis. So they either had severe renal artery stenosis or they had a big pressure drop across their stenosis. So this is proper renal artery stenosis. The second thing is that this study was powered for events. So it was looking at MI, stroke, vascular death. And it was a lemon, it was negative. It did lower blood pressure by 2.3 millimeters, which is significant, but do you want to do this for 2.3 millimeters? Probably not. So I think this is going to make us rethink what we do with renal artery stenosis. We kind of stop really looking for it. We do it occasionally if we want to salvage a kidney that we think is going to just thrombose off and get killed completely. But we don't do it for blood pressure anymore. And certainly in terms of outcome, it's probably you shouldn't do it for blood pressure anymore, unless we can just find some subgroups that in who it does help. It doesn't mean that we shouldn't do it for fibromuscular dysplasia, by the way. So I was at this meeting at European Society of Cardiology, and all the cardiologists are salivating, thinking that, look, hypertension comes home to cardiology. It's now going to be an interventional thing that cardiologists can do to cure. Now, going back to we've gone through the novel sort of perhaps sublime things. Let's go back to the mundane, because go back to sodium and salt intake. This was published yesterday. I don't know if you've heard it on the news, but we were rather worried that a lot of tablets contained a lot of salt. And so we did this study comparing salty tablets with the equivalent tablets that didn't have salt. And we found an increase in cardiovascular events, mainly driven by stroke, 22% increase in stroke. But the interesting thing was there's about a 7-fold increase in the diagnosis of hypertension in people who take chronic salty tablets. And it just reminds us that there are probably things out there that matter more than a ROX device or deep brain stimulation in terms of preventing events in the population. There's probably 1/3 people in Britain take chronic soluble paracetamol for various ailments because they can't take NSAIDs anymore. And that's a lot of increased stroke risk at 22%. So, in summary, I think there's quite a lot of interesting things and innovative things happening in hypertension. I think there's lots more to come. And I'm probably going to get not very many, the President's probably not going to be happy with me for my next slide, because the British Hypertension Society meeting is going to be at the other place. Your place was not available, but it's going to be the other place this year, and it's really going to be an interesting meeting with a scientific track and a clinical track. And BHS is now an open society, and anybody who wants to hear more exotic and interesting stuff about how to manage blood pressure would be very welcome. Thank you very much.
Oh my goodness, we've got an email here in what looks like Arabic. Okay, this is a question, Tom. I'm really sorry, but I can't tell where the question is from.
This question is, what is the role of probenecid treatment besides allopurinol? Well, I can tell you that, actually.
You can contribute to it, guess.
Do you want me to tell?
Yeah, just kick off.
Probenecid.
Yeah.
It works if nothing else works, but it's not very effective, and it just blocks acid transport in the proximal tubule. And I don't know, it's one of these things you use when nothing else works, is that right? That's about it, there you go.
There you go, thanks for that. Another question at the front. front together. Yep.
Thanks, Mark Andrews from Norwich. I don't know if is it wrong, but I love to hear you talking about kidneys. It's
Oh, yes.
but
You're a nephrologist,
yes.
is that right, Mark?
Patient selection is what I want to ask, because, as you say, everybody is salivating at the idea of an intervention, but patient selection seems paramount. I know you know a lot about drug compliance. I wonder if you could share a bit of that with us.
Yes, I mean, one of the interesting things is that when you start to look for people to do renal denervation in, and you have a set protocol, and you do directly observed therapy, because you take them in the hospital and you give them their drugs to make sure that the blood pressure doesn't fall, and it does fall like a stone in a lot of people. And then they say, oh, well, maybe I missed some of my tablets. And so it's hard to find people who would fit. So we've only managed to do 5 of these. And it only worked in one of them. So, and actually the process of actually going through the process of trying to find somebody who fits often cures their hypertension. You just give them a lot more help and attention. And in Leicester you can now get hypertension drug levels measured directly. And these people have no drug in their urine at all. And that's the most objective way, I think, of doing. I think we probably need to roll that out throughout Britain, because there's no point in spending all this time, effort and money. On the other hand, the role for renal denervation might be in those who won't take the tablets. That might be the role for it in the end. But I agree with you. It doesn't, in our hands, clinical practice doesn't work in everyone.
As you suggest, it might focus their mind around the question of compliance if you offer them renal denervation. Peter, a question.
Terrific talk, and you covered the sublime through the ridiculous, but not the mundane in terms of something like diet and exercise. A lot of dose response curves. Is there such a thing as a dose response curve for weight loss or for dietary alteration? And equally, can you tease that apart from the placebo effect?
Well, diet, we think, for every kilogram you lose a millimetre of blood pressure. So that's reasonably well established. Exercise, probably the benefit of exercise in preventing cardiovascular events. It has a minimal effect or mild effect on hypertension, but we tell people to do it because it's linked to weight strongly. Diet works if you can stick to it. A diet rich in fruit, vegetables, low in saturated fat will lower your blood pressure as much as a drug. But people changing their behaviour, that's the hard thing to do. You can't get people to stop smoking. Fat people are always fat. It's hard to change behaviour. And we try and do it, but in the end of the day, you end up giving people tablets because you hope they'll take them. And it does. Hypertension is the most evidence-based thing we do of anything. And treating hypertension is cheaper than not treating hypertension. So we end up giving them drugs in the hope that will make them live longer.
Thank you very much, and good to know that you're as politically incorrect as ever, Tom. Thank you. We're scheduled to break for coffee at 11:10, and Mike Jones has 5 minutes to tell us about the Acute Medicine Network. And every minute, Mike, you take beyond that, there's a minute off the coffee break. 5 minutes is yours.
Thank you very much, John. In the middle of a good programme, we're watching television, the adverts come on. I'm afraid I'm that. They're really irritating, but I just want to take 5 minutes of your time. The pads you have don't have an on-off switch and they can't mute me, so don't try. Acumen is the Acute Medicine Network for Learning. Many of you will have heard about it, but we're now trying to promote this far more on the basis that its usage is increasing. It has been developed between the 3 Royal Colleges of Physicians and the Department of Health in England and taken over by e-Learning for Health, which is now a significant department running many electronic learning systems across the specialties. This one was developed to try and cover the content of the CMT, acute internal medicine and general internal medicine curricula, because they're all based around the same sort of format, looking at patient symptoms. We originally planned to do 800 sessions with an editorial board to review contract, honour area for authors, and then we hit financial cutbacks. So over the last 18 months we've been doing this on a shoestring. The Department of Health is now looking at getting more money into this, and therefore we are reinvigorating the process, but just to show that we are actually constructing this in a sensible way, we've had a small team of instructional designers. The scenarios that are developed are to try and mimic the way a patient would present. So the trainee undertaking the training will take a history from the patient on the session, we'll have an order comms type of keypad to organise investigation, get the result of investigations back, and then be able to plan both a management plan and also create a differential diagnosis. And then we'll be able to compare their own individual efforts with those of the expert that wrote the scenario.
Hello. Yeah. I think many people arrived after the photograph. How many people would like to information about the work that we're doing in TriMed? Please do try and understand the work we are doing, and if you have any questions, please do feel free to ask us. Our TriMed team here is here, and Dr. Rama is here. I'm here. We are all happy to talk to you about what we are doing as integrative medicine for the management of chronic medical disease. So welcome once again. Please join us for the photograph. Please join us for tea. Thank you.